Assalamualaikum candidates. I am Dr. Nadia, gynaecologist and online teaching mentor. Now, today we will conclude about the lecture being which we are dealing regarding the liver disorder in pregnancy. So, before proceeding towards the liver disorders, first we have to understand that what normally the liver is meant for. For it, you have to know that normally what happens that liver is actually the main organ where normally the glycogen stores they are glycogen is stored inside the liver, and certain clotting factors which are actually vitamin K dependent, these are 2, 7, 9 and 10, they are being synthesized inside the liver, and also the certain binding proteins are being synthesized inside the liver. And also the important thing is that detoxification of certain fatty acids, long chain fatty acids or certain drugs is being carried out inside the liver. And also the process of if the RBC, once the bilirubin is produced because of the breakdown of RBCs, that is being metabolized and ultimately converted to biliverdin, and that in turn is excreted inside the stool or even in the urine in the form of urobilinogen. So actually the liver is a detoxifying organ of the body which is involved in all these activities. So it's not only involved in maintaining the glycogen stores, but also in coagulation, and also in the also the carrying out different main metabolic activities of the body. Now what happens, the liver dysfunction can occur because of many causes. This can be some viral infection. So the viral infection can either be hepatitis A infection, but all of you know that hepatitis A infection is not that much toxic because it usually resolves, and the transmission is by means of the orophycal route. And whenever there is damage to the liver parenchyma, then it in turn results in rise in the level of liver transaminases. So basically what happens that SGPT and SGOT, they are actually raised in case of liver damage. And also once the bilirubin is raised, ultimately it will impart a yellow discoloration to the skin, to the sclera and to the conjunctiva. So ultimately there can be jaundice, but it subsides in the few days. And similarly the other infections are like hepatitis B infection can be there, hepatitis C infection can be there. Regarding the hepatitis B infection, you must remember that if there is presence of hepatitis B E antigen, then it indicates that there is acute virulence, it's highly toxic. So definitely we have to go for PCR test, and that PCR should be quantitative to confirm that what is the load of viral infection. So we have to start with the medical management, and we have to assess the benefits and risks of the medicines in pregnancy, and accordingly we have to follow the patient. And also we must remember that in case of hepatitis B infection, there is a risk of risk of transmission of infection from the placenta to the fetus. So ultimately this risk of transmission, keeping in mind, we have to be vigilant in the pregnancy, and in a way that we have to choose elective lower segment C-section. And also we should after delivery of the fetus, we have to go for the active and passive immunization of the fetus, so that the risk of transmission is reduced to the fetus. Similar is the case with hepatitis C infection. Once we know that mother is having hepatitis C infection, then in that case we must remember that there is risk of transmission, vertical transmission from the placenta to the fetus, and ultimately not only mother has to be followed, but as far as this baby is delivered, then definitely you have to give the active, in this case, you know that actually the hepatitis C virus infection, for hepatitis C virus infection there is no immunization available. So definitely just we will give this fetus immunization protection against hepatitis B infection. And also we have to follow this baby after handing over to the pediatrician for any acute infection or sign symptoms of the infection. And now what we have to be concerned about is then obstetric cholestasis. As I have discussed in my previous lecture, that in obstetric cholestasis what happens, that there is actually because of estrogen there is stasis of the gallbladder. So because of this stasis, the bile which is to be excreted from the gallbladder to the to be added to the food contents for digestion, actually for the digestion of the fatty food. So this bile is not actually, because of stasis of the gallbladder, this bile is not moving forward, rather it's moving in the retrograde, like backward movement. So because of this, the levels of bile acids will be raised inside the circulation, and because of this rise in the levels of bile acids inside the circulation, inside the blood, this leads to itching, to the complaint of itching in the patient. It happens mostly in the third trimester, and it may continue till 6 weeks postpartum, and the patient has itching, and that itching is without rash. So she will complain that she is itching mostly on the palms and on the soles, and but you will not see the signs of this itching, because no specific signs like redness or any marks of the rash will be seen in this patient, but complaints will be there that she is very much annoyed of this rash, like she is having rash, and she is having difficulty, and she is having difficulty in good sleep. And also we have to very much we have to be important to rule out the cause behind. Now here we have to keep in mind two type of differential diagnosis. One differential diagnosis regarding the skin disorder, because she is having itching. So regarding itching, you have to rule out any skin disorder, like either it is scabies or it is pemphigus, either it is a polymorphic eruption of pregnancy, or it is any other insect bite, or it's in the form of villi leading to pemphigus gestation, pemphigus gestationis. And so all the complaints related to the skin disorder have to be ruled out. And if the patient is having liver dysfunctioning, and ultimately she has deranged liver function tests, and also she is having raised bilirubin levels, so you have to rule it out. Either it is because of viral hepatitis, either it is because of some other liver dysfunction, either it is because of some congenital obstruction to the duct. So all the causes of this liver dysfunction have to be ruled out. Now actually the obstetric cholestasis is a diagnosis of exclusion. Once all the things are ruled out, and then you have to classify it as obstetric cholestasis, and not a single test is there which is going to detect the which is going to assess the good viability of fetus in this case. Because what happens, that in spite of normal Doppler ultrasonography or normal CTG reporting, there is risk of certain meconium aspiration and certain IUD in case of obstetric cholestasis. And because of this backward movement of the bile and rise in the bile acids, there is damage to the liver. So this ultimately this results in rise in the levels of transaminases. Also bilirubin level might raise, and patient might experience epigastric tenderness because of liver liver inflammation is there. And ultimately you have to keep in mind about the management, that early that you have to deliver the patient at 37 weeks and not go beyond this gestation, because there is risk of sudden intrauterine death, and no test is there to predict the good outcome of the fetus if we continue the pregnancy. And similarly, since as I've told you before that the clotting factors, vitamin K factors like 2, 7, 9, 10, they are being synthesized inside the liver. So liver dysfunction can be there. So patient is at risk of developing disseminated intravascular coagulation because of this, because coagulopathy might occur in the patient. Now when a patient comes to you with these complaints, definitely you have to assess the mother as well as the fetus. Regarding the mother, she has complaint of itching, so you have to give her medical management, and which can be conservative and specific. Regarding the conservative management, you can give emollients, you can give soothing agents, you can give antihistamine. And regarding the specific management, you can give the patient ursodeoxycholic acid. What happens that ursodeoxycholic acid actually enhances the excretion of bile acids from the body, and ultimately leading to reduction in the levels of the bile acids. So although the LFTs might come back towards slightly towards normal, and although the itching might be relieved, but again the thing is that you cannot assess the good viability of fetus based on this. So definitely you have to plan delivery after giving steroid cover to the patient. And similarly, another dysfunction is acute fatty liver of pregnancy. In acute fatty liver pregnancy, what happens that mitochondrial dysfunction in the liver is there, in which there is actually an enzymatic defect, in which actually the long chain fatty acids are not being degraded by the enzyme, and ultimately these long chain fatty acids, they cause the liver dysfunction. And once there is liver dysfunction, this in turn leads to inflammation of the liver. Whenever there is inflammation of the liver, this in turn leads to rise in the level of liver transaminases, and SGPT, SGOT as well as the bilirubin level, they will be raised in this case. And also the as I've told you before that the main function of liver is to store the glycogen. Once the glycogen stores are depleted because of liver dysfunction, then this will result in hypoglycemia. So in acute fatty liver pregnancy, there is a hypoglycemia, and also there is marked elevation in the level of liver enzymes. And also if significant, it can lead to hepatorenal shutdown. There is involvement of liver and as well as the kidney, and ultimately not only the liver enzymes are raised, but also the liver renal parameters are also deranged, and ultimately this patient can go in encephalopathy. So it's an emergency. You have to plan the delivery because it can be toxic to the fetus as well, and ultimately because it is a pregnancy related disorder, so after the pregnancy is over, it will be okay. So this was about acute fatty liver pregnancy. And third is the HELP syndrome. So what HELP syndrome signifies? H stands for hemolysis, E stands for elevated liver proteins, and P stands for low platelet count. So all it's actually a part of preeclampsia, complication of preeclampsia. So in what happens in preeclampsia, that because of improper placentation, there is endothelial damage, and there is widespread endothelial damage, and ultimately leading to widespread consumption coagulopathy, widespread damage to the endothelium, and ultimately this in turn leads to damage to the various viscera, and this also damages the liver, and ultimately because of this damage to the liver, there is elevated liver protein. So again the liver transaminases will be raised in this case, and also since the platelets are being consumed because of the widespread subendothelial damage, so ultimately because of this consumption of platelets, the platelets count will be reduced. So at one time the liver dysfunction is there because of endothelial damage. So because of this liver damage, the liver enzymes are raised, and at the other time platelet counts are low. So all these lead to great risk to the patient regarding the disseminated intravascular coagulation. So patient is at increased risk of developing DIC, So definitely again in this case, because it's all because of placenta, because of improper placentation, because of subendothelial damage. So ultimately the solution is to deliver the patient. Once you deliver the patient, the placenta is taken out, the patient will slowly revert back to the normal. But definitely you have to follow the liver enzymes and liver function test in the patient, and accordingly you have to monitor the blood pressure, vitals, intake, output, and bleeding provisionum in the case, and also you have to monitor the liver function test. So these were the main liver disorders which are associated in pregnancy. So you must remember that what are the differential features of these disorders. I have discussed with you that these can be because of viral hepatitis, it can be because of some obstetric cholestasis, it can be due to an acute fatty liver pregnancy. And what are the differentiating features between all these, you must remember. And if any scenario comes to you regarding the liver disorder, you must remember that hypoglycemia is specifically a feature in acute fatty liver pregnancy, and similarly the itching without rash and itching mostly on the palms and soles is mostly seen in case of obstetric cholestasis. And also if it is viral hepatitis, definitely patient there will be history of any if it is B or C, there will be history of hepatitis viral infection because of IV drug abuse, or the routes which have that how is it transmitted, and there is risk of vertical transmission from the placenta to the fetus, and how to prevent this transmission. You must know these things. And it was all about conclusion regarding how to conclude the liver disorders in pregnancy. Thank you.